Good evening, everyone. For those that don't know me, I'm Becca Akoto, Director of Racial and Social Justice Advocacy at YWCA Delaware. And tonight we're going to talk about mental health, which is an extremely important topic. I think it's a topic that we talk about a lot more than we used to, which is wonderful. And I have three great panelists to go ahead and guide us through this conversation. Although psychology was my major, I don't have a degree in clinical psychology. So everyone, first, I'm just going to kind of introduce everyone and then let them kind of talk to you about what they do. Marsha, and I'm going to say this, I should have checked, Akoto.
Akoto, yeah.
Akoto. That's how you spell Akoto. My name's is a community-based counselor working with Jewish Family Service clients in community, school, and home settings. Ren Kinnear is a licensed clinical psychologist who provides individual therapy within the Philadelphia and Delaware region with specialty in LGBTQ therapy. And then Tomaro Pilgrim is a clinical social worker therapist, and she works at her nonprofit as well as being the executive director of Tomorrow's Change. Okay, so we'll just go in the order I just said. If you guys would just kind of talk about what it is that you do every day with your profession.
Thank you. So like Becca said, my name is Marsha, and I work at Jewish Family Services of Delaware, and I'm a community-based therapist. I'm also a rising third-year PhD counseling psychology student. So at JFS, I work in the RISE departments, and we work with refugees, asylum seekers, and immigrants. And I do a lot of program development, cultural adjustment groups, and essentially helping them adjust to life in America and providing them mental health support.
Awesome. And Ren?
Yep, so I'm Ren Kinnear. Right now I work with a group practice, collage therapy collective based out of Philly. So I see clients in PA and Delaware, and I primarily do, queer-based therapy, a lot of gender affirming care. So I work with a lot of queer individuals, trans individuals, as well as surgery letters, stuff like that, so that people can access additional medical care.
Great, thank you. And Tomaro?
Hi, my name is Tomaro. I am the founder and executive director of Tomorrow's Change. We are a nonprofit organization, and we have an office in Claymont and in Wilmington. And we provide therapeutic support to youth and families with a great focus on those who are uninsured or underinsured. We assist all ages, however, we do prefer working with youth and their families. And we cover a broad range of issues.
Other issues. Thank you so much, all of you. And then my first question is going to be for each of you. What drives you to do what you do? Why are you in the position that you're in? And we'll start with Marsha.
Sure, yeah. So I've always really been interested in mental health. I've always been an advocate for mental health. I think it's really important to take care of your mind because I definitely believe that the mind and the body is connected. So that's something that I've been passionate about from a young age. And as I've gotten older and entered the field and honestly seeing my clients' lives change and essentially helping them, find their strength and find their voice and rewrite their own stories is honestly what motivates me and empowers me to keep doing what I'm doing.
Thank you. Ren?
I think, I feel motivated to do this work because I feel like as a queer person growing up in the world, I think there was a lot of time that I felt very isolated. And I feel really passionate about creating a space for other folks to have support and not have to experience that isolation.
Thank you for that. Tomaro?
I guess the more obvious reason why I do what I do is because of a lot of situations that I've had in my past, whether it be through my childhood as well as a young adult. a single mom as a teenager, and it's a combination of things. But I think that over the years, going from just wanting to be a person who helped other people, I've developed a passion for the security of an entire family. So my passion has grown from just wanting to help individuals to making sure that there's a nice solid foundation for families to raise their children, you know, keeping in mind that their children are going to have children and so on and so forth. So the drive for me is just, you know, help one person at a time. And I feel like I'm helping villages.
Yeah. Awesome. Thank you. And thank you all for what you do, because it's so essential. So we're doing these Let's Talk in tandem with our 21-day equity challenge. And I know not everyone watching the Let's Talk, some people just come for the topic and some people come because it's part of the 21-day challenge for them. But we're going to kind of talk a little bit about some of the materials that were discussed in the challenge. And so I'm going to ask, like, regarding racial disparities in McDiag. Wow, that is weird. Okay. Regarding racial disparities in mid-diagnosis, Black men, for example, are overdiagnosed with schizophrenia. In fact, 4 times more likely than white men to be diagnosed, while underdiagnosed with post-traumatic stress disorders and mood disorders. So research indicates that compared with people who are white, Black, Indigenous, and people of color, BIPOC, are less likely to have access to mental health services, less likely to seek out services, less likely to receive needed care, more likely to receive poor quality of care, and more likely to end services prematurely. And I'm going to add the queer population to this because I think a lot of these can apply to the queer, although I have Ren talk to me about that. So why do you think that is? So I'm just going to less access, less likely to seek out services, less likely to receive the care that they need. And if they do, poor quality, and more likely to end services prematurely. And we'll go backwards tomorrow.
I think for one, and I think we all agree with the stigma. It is getting better, but there still are issues with stigma. I think that it's generational as well. The younger the client is, the more potential that we'll have of them coming in. Definitely has to do a lot with culture. I know for people of African descent, whether it be Caribbean or American, we have, you know, this kind of what happens behind closed doors stays behind closed doors. We have the religious aspect of it, where if you're going through anything, you know, pray about it and God will help see you through. You know, so we have all of these ideologies that put us in a position where we feel that we don't need to, or it makes it difficult for us to want, or even, I've even had clients tell me that they physically could not bring themselves to therapy. You know, and then it's that other thing of, you know, if you have mental health issues, then you're crazy, there's something wrong with you, or, you know. So I think it has a lot to do with what we've been taught through society, as well as what we've been taught culturally.
Thank you. Ren, if you want to.
Sure. Yeah. I think one of the things that I'm thinking about too is, you know, psychology as a whole and as a field has a pretty dark history of treating people, you know, in a way that was pretty harmful. And so, I mean, I think the way we talk about mental health now is as if we're disconnected from that history, but it really wasn't that, you know, far back. And so I think that that really has an impact on, you know, what people expect from mental health, or what messages or stories they've heard from their family or from, you know, the people older than them about what it means to access care.
Thanks for it's a good thought. Marsha?
Yeah, and just to go off of what Ren said, you know, it's really important for us to understand that there has been a lot of medical mistrust and institutional mistrust in this country. And, you know, even controlling for that, if people of color bring themselves to start seeking services, there's a disconnect even between the language between like providers and the clients. And so clients might be more likely to use the word I feel blue, or I feel fatigued, or I feel down, just using different language, and they're not actually using the descriptors in the DSM-5. And so it's easy for them to be misdiagnosed, or for their symptoms to be overlooked. There's also so many tropes in the Black community. So if maybe a Black woman goes to speak to her primary care physician and she's saying, I'm just really exhausted, I'm working really hard, I'm a single mom, the primary care physician might be conditioned to look at the Black woman as, well, she's supposed to be strong, so she's built for this. She doesn't feel pain. And so symptoms can be often ignored.
Thank you. I'm going to touch on that a little bit more, only because I have a friend that posted just about this the other day on social media. The statement that you used, the strong Black woman. And she talked about how that really puts Black women in a place where they feel they can't ask for help, and that they are supposed to handle more than any of their counterparts. Is that pretty much? Yeah. Yep. Okay.
Yeah, absolutely. Yeah.
How do you combat that narrative in therapy? Anybody?
I don't, the reason why that question is a little difficult for me is because it has to be individualized. It just depends on who the person is, what their situation is, and their level of that feeling, that emotion. There's not one thing that works across the board, but it is definitely a conversation that I have with many of the women that come through my office, people of color, and that goes always, whether it's the man or the male or the female. But you both made some really valid points. I wanted to mention when Ren talked about the way psychology is viewed. I did a blog post. I can't remember if it was last year or the year before, but it was very shocking for me. I don't know why, but it was that the US put out a letter apologizing for the damage that they've done to the people of color, and it was across the board, indigenous people, people of African descent, so on and so forth. And it was just interesting to see that this letter had been put out there, and not only was it put out there, but no one knew about it. It was not talked about. It didn't, hit all of the social media and the news. And so it was quite interesting to me that this is such an issue, but it's not something that we're hearing about. And then, to Marsha's point, same thing, you have the situation with the Black women who are struggling, like, do I deal with this issue on my own, or should I go in and talk to someone? So it's interesting that it's not something that's talked about as much as it should be.
The one thing we didn't address there was the access and quality. Why do you think that's a barrier?
There's not many of us. And if you look at what all of you are saying with regard to the disconnect, if you don't see people who look like you, or who present themselves as being able to understand where you're coming from, then that makes it that much more difficult. And we already have a shortage in psychiatrists and psychologists and therapists, but then on top of it, there's not enough people of color. And that is definitely a huge issue.
Marsha, you feel the same? You think it's kind of the...
Yeah, absolutely. And even just like the physical barriers, healthcare is not free in this country. So, even the issues with insurance, and how that impacts individuals, or, you know, even access to literature on, you know, mental health, where to even get started. A lot of people, if they do want to access mental health services, they typically, their first stop is the schools or primary care physicians. And so if they're even having a barrier to getting to the schools, or barriers to, you know, the doctor's office, then there's even, you know, they have to jump through so many hurdles to even get to mental health services. So, yeah.
Do you
Yeah.
think that that is changing all of what we just talked about? You think it's getting better? Think we're having more therapists, non-traditional therapists, perhaps?
Yeah, definitely. I think that it's improving in some ways. It's a slow and steady change, but there are definitely non-traditional therapists. And I think that as therapists, it is our job to, part of, you know, making mental health care more accessible, is to reach out to the organizations that people are going to go to first. So as Tomaro was saying, you know, for a lot of Black people in the community, church is their therapy, you know what I mean? So if we can get in there and maybe train pastors or train elders on how to deal with people who are having mental health services. Also, I've done some readings on how for Black men, their therapists are the barber shops. And so, you know, even going in there, posting a mental health flyer in there, or a business card in there, or training, you know, barbers on how to talk to their customers. Meeting people where they are is part of making it more accessible.
That's really great point. You talk about that with all the services that we offer throughout the state. Is if they're not accessible, people don't know about them. There's
Right.
not point in having them.
Yeah, yeah.
I think to Marsha's point, like the way that healthcare is structured in our country and the way that that makes these, you know, services really inaccessible. I mean, I think what immediately came to mind for me in relationship to, like, you know, the LGBTQ community is, you're thinking about young adults who are potentially isolated from their families or disowned from their families, who are couch surfing, who don't have health insurance, right? And therefore don't have the option, you know, it's not affordable to access care. And so, yeah, I mean, I think like without some major reform in terms of our health insurance system and our health access, like, you know, financial system, so many folks just, yeah, fall through the cracks there.
Yeah, is tomorrow, is that one of the reasons? Yeah, I was gonna
That's
say,
one
is
of the
that,
reasons
yes.
why we focus on young people who are uninsured or underinsured. We seek out grants that allow us to provide these services for free or low cost. So when we first started doing it, it was right after COVID. And of course, at that time, people were losing their jobs and you know, or their insurance coverages were shrinking. And prior to that, we had already, you know, we already saw that this was an issue because many of us worked in the school systems. And, you know, if you're seeing a student and the student's parent can't pay the $20 a week copay, before you know it, they are told that they can't come in, you know, you can't see them anymore because, you know, of course, you have to pay the therapist, you know. So that's one of the reasons why it was so important for us to do what we do. And it's so unfortunate because we had to cap it at an age, but when you look at all of the people, for example, we just received a grant for single moms who are raising kids who are in therapy. You know, we got your kid in therapy, but what's the sense if we can't help you figure out where you're struggling? Because typically it's not just a kid issue, you know? So yeah, I've been talking to different politicians here in Delaware, just wondering, like, what are we doing to try to make it so that these people who need therapy can get therapy? Because it just makes no sense. You know, you don't have insurance, or another issue that I've been finding, and I don't know if you ladies have seen this, but if a client doesn't have a diagnosis, they may be, I call it they need situational help. So a situation has them feeling a certain way, So if we can address the situation at that time, it may not become a bigger issue later. But we can't do that without saying they have a diagnosis, because then insurance won't pay us. So it's insurance is just weird. It's an issue. It's an issue.
It's interesting that you mentioned that, Tomorrow, because I remember that. So I'm not to give away my age, but I'm going to be 50 this year. And the first time I went to therapy, I think it was 21. And I remember then her having to diagnose me. And at 21, especially 24 years ago, I was like, no, I don't know. I pushed back for a really long time. She wanted to prescribe medication. I mean, it was this whole thing about being diagnosed, right? And she's like, I have to put down something. Like she was just like, I just need to get paid. I don't really care what, and as I have a therapist still, I think everybody should. But it's one of those things that really kind of backlashes even to the client, I think.
And how you just mentioned that you still have a therapist and you think everybody should. Could you imagine if we all were able to just get a therapist? Not because we are experiencing any kind of issue that needs a diagnosis, but just to have somebody to talk to check in with, we all don't have that person that we can share with, or, help us come up with solutions, or, it's.
Yes,
What?
yes. And that's very much from my my place of privilege now. And the times in my life when I didn't have one was when I didn't have insurance. And that's really scary when you're on a medication,
Right.
and you lose insurance. And it's one of my biggest fears. I don't know if you guys have that a lot with any of your clients, where their biggest fear is, if I leave you or I can't afford you, then I can't also get the medication that's helping me.
Yeah.
Are any of you med providers? No. Because there's there's nurse practitioners, depending on the insurance, that can now prescribe medication. They no longer always have to have someone like a psychologist over them, which I think is great. There's some women out there starting their own businesses doing that. So, all right.
We've been looking for one of those.
What was that?
We've been looking for one of those.
Have you?
Yes.
Well, we'll talk
Yeah,
offline if
we
you
have
haven't
a
already
hard
found
time
one.
with the young ones, when it comes to that. Again, because of insurance not covering medications and that kind of thing. So yeah, it's been hard.
So despite such efforts, racial disparities still exist, obviously, even after controlling for factors such as income, insurance status, age, and symptom presentation. These are additional barriers, which I think we all kind of talked about. The different cultural perceptions about mental illness, help-seeking behaviors and well-being, racism and discrimination in and of itself, greater vulnerability to being uninsured, access barriers, and communication barriers, and fear and mistrust of treatment. You guys hit them all. I didn't even read first. In addition to emphasizing culturally competent services, other recommendations for bridging the gaps and addressing barriers have largely focused on diversifying workforces and reducing the stigma of mental illness in communities of color. Now, Marsha, I'm going to ask, because I'm not 100% sure of the process, but I know JFS is working on a particular programming, bringing people in, having them be trained, especially therapists of color. Would you mind sharing a little bit about that program? And I'm not sure if you're part of it. You probably are.
Absolutely, yeah. So JFS has created a fellowship program, and essentially the fellowship program is to take in master's level therapists, train them, and then help them, give back to the Delaware community. So it's kind of like, we invest in you, you invest into the Delaware community. 50% of the staff that were hired through this fellowship program are people of color. And this is really important because our clients are predominantly people of color. And it's not even just about color, it goes beyond color. Also, gender identity, sexual orientation, religion, class, all of that. And so JFS is really big on having a diverse network, because we want to make sure that our staff represents our clientele. It's not enough to just have a mission statement on your website anymore. It's not enough to say that, you know, you're all about inclusion and diversity. Essentially, JFS is really big on, you know, demonstrating that by hiring staff. It's also bridging the disparity between higher education. A lot of people of color, you know, hitting that barrier, not being able to, you know, having like issues with like testing or like paying for, you know, the NCE exam, all of that stuff, all of those barriers that people of color experience in higher education. JFS helps them with that. And so they pay for, you know, the tests, they also train them, they give them study prep, all that great stuff, essentially helping them so that they can help other people. And so we've been able to see how this program has helped clinicians, and it's also helped our clients out there. We had a long wait list for a very long time, but now we're getting people off of that wait list. And it also is just helping clients see that we care about them, because when they see staff members that look like them, or even if they don't look like them, or even if they don't share the same identity, having staff members that are trained and they're presenting like issues, having staff members be trained in that, it shows them that they matter, it shows them that they care. So it's a great program. I am a part of it. And yeah.
Great, thank you. Yeah, I remember, I want to say, is it Rena? Is that your, yeah, I
Yeah.
remember talking to Rena, who's the head of JFS before you guys started this program. And I was just like, wow, that's a great program. We could just multiply it everywhere, right?
Yeah.
Part of our issue. Now work the way I wanted it to. All right, so the prison system is the place that Black men predominantly come into contact with mental health support. Now, despite it being prison, do you think it's good for this to be happening, that they're getting mental health support, or do you think it's not the right care? We seem to have gone from institutions directly about mental health, right, to now we put people with mental health issues in the prison institution. Anyone want to? All of you are just smirking and shaking your head like, yep.
I'm not 100% in tune with what's going on in the prisons, especially here in Delaware. I'm not really sure. But from personal experience with family members, I can honestly say that I think that it should be something that is offered in the prison. Actually, any institution where you find people are frequently being diagnosed with some kind of mental illness. But I think that in implementing it in a prison, it should be a goal. And the goal is to actually make sure that we're working to make sure that these people who are in prison are getting really what they need, and not just, oh yeah, they're seeing a counselor. You know, oh yeah, they're seeing a therapist just for the sake of saying that they're seeing a therapist. It should be some really deep work, because when they come home, they're coming back home to the same exact situation, you know, and the same exact mental health issues with no tools. You know, they have no tools to bounce back or to stay safe or to make better decisions. So I think it should definitely be implemented.
Thank you.
Yeah, I agree that it should be implemented. And I'm also really big on preventative care. So as a community-based therapist, I did work with young Black boys that were court committed, youth boys in the school system. And a lot of the work that we were doing was trauma focused, and it was preventative work so that they won't end up in the prisons, because there is no guarantee that, I mean, any prison can say that they're providing mental health services, but, you know, what types of services? Is it adequate, you know, services? Safety is also a huge concern. Even if they have a 1 hour session with a therapist, they're still going back to their cell. They're still, you know, making less than 5 cents an hour, and, you know, doing all of this, you know, dangerous labor and all of that stuff. And so I don't think it's enough to, bank on the mental health services in the prison. I think that's important for us to get in before they even make it to prison. And that can be implemented in school. There is a direct pipeline with the school to prison pipeline. And so that's why I really think it's important to invest in mental health services in the school. Young Black boys are suspended at a higher rate than any other race, even in preschool.
Many times.
Yeah, and so it's really important to do that preventative work, because by the time they get there, to prison, we don't know the types of conditions that the services are, being given to them.
Yeah, I agree completely. I was thinking about the school to prison pipeline and kind of how we do something there, and it sounds like both of your community work is certainly doing that. I think the other thing that I was thinking about is, I've worked with adults who, are coming out of incarceration, and the full lack of any coordinated care from incarceration to back into life, kind of sets folks up for failure to return, right? So it's great to have services within the prison for them to work on their mental health within that structure. But if we don't then provide some bridge to accessing mental health care when, someone is in the community, right, then we're not doing a full service to that person.
Yeah, very, very valid point there, Ren. And then, Delaware is one of the highest recidivism rates in the country, like 70% or something. So, I mean, we don't set people up for any kind of success. And I think mental health would just be, but to your point, Marsha, I think you were talking about too, just the stress of simply being in prison, right? That's, let alone if you have any kind of mental health issues. I think that would cause me to have mental health issues, right? You're living this other kind of life that's not safe, kind of how you mentioned, and it's not, you don't feel secure. So that having a lot to do with it. How do you think racism affects mental health?
It affects it in so many ways. So racial trauma is it's a condition that's actually not recognized in the DSM-5, but even though it's not, credited in the DSM-5, it is a very real thing. And just having, whether it's an event that was racist that happened, or whether it's, lifelong oppression, lifelong discrimination, lifelong racism, it really does take a toll on your mental health. It takes a toll on your self-concept. It takes a toll on your self-esteem. It takes a toll on your physical body, your sleep, your appetite, especially if you don't have outlets to deal with the trauma that you're going through, or the anxiety or the hypervigilance that you're experiencing from an encounter, or just lifelong racism.
Thank you.
Yeah, all of that.
It was interesting to me, the DSM-5, obviously, I don't know specifically what that stands for, but that's like legitimizing a mental health illness, right? So we'll talk more with Ren about what that used to look like. It's not, so racism isn't, so trauma from racism isn't even isn't a diagnosis at all?
It's not a diagnosis. No.
Okay.
No.
That's what happens when you live in my world. I think everything is being addressed, and that's not great. So have any of you heard of Resmaa Menakem? If you haven't, it's okay.
No.
Okay, so he wrote a book called My Grandmother's Hands. And what he talks about is
Oh, I have that book. Interesting that I didn't recognize the name.
I'm probably saying it wrong. How about that?
I just bought it not too long ago.
Oh,
It's sitting on the shelf.
So what he talks about is the trauma that lives in our DNA. and how that kind of progresses throughout time. Perhaps, you know, children weren't obviously have the same trauma that we had. Any of you want to kind of talk to that a little bit? I can explain my little piece, but I'm not in the space. So about living with like trauma and the DNA and whatever you want to go with.
That's a loaded one, wouldn't you say, Marsha?
Yeah,
It's like trying to condense the response.
yeah, yeah.
Well, he also talks about, which I found interesting, when you get to his book, he actually talks about the trauma for white individuals as well.
Mhm.
And, you know, just, you know, if you look out throughout time and you can look at, you know, Jewish individuals, you know, from slavery to losing your land, you know, oppression, obviously it's different in the United States, but the belief that that continually lives on,
Mhm.
and just gets compounded, right?
Yeah.
With people's own.
Yeah, I'm glad you brought that up because I was going to mention how there have been studies done on descendants of survivors of the Holocaust, or you know their lineages from the Holocaust. So there has been studies done on that. There haven't been studies done on African descendants of slaves, unfortunately. And so it would be interesting to see how African descendants of slaves, or ADOS, the DNA, and seeing how, you know, trauma has been passed on, not just psychological trauma, but like physical trauma. And so I think that, you know, there's a lot of work that needs to be done in the field. But I think that, you know, talking about, you know, Jewish people and looking at their trauma is a start.
Yeah.
And although there's not unfortunately there's not data per se to show, but if we take a good look at what we see as therapists, what we read, and I mean the truthful stuff that we read and that we see, you look at the people that you see on social media, and the evidence is there. You know, it is definitely DNA trauma. It is definitely physical, whether it be mental or like physical, you know, illnesses, medical traumas, you know, that have been passed down. And I don't think that, of course, it would be wonderful to have some kind of data to track all of that, but I don't think that that's necessary for us to realize that the issue is here, and that something needs to be done to assist ourselves and the communities in those issues. How? I guess we really haven't figured that part out yet, you know, not even for Jewish and other communities that have experienced any kind of oppression. But it's definitely a start here when we're talking about mental health the way that we are.
Right. Well, and I do believe there have been animal studies that have shown the passing of trauma or fears and fear responses based on, like, you know, whatever higher generations. I mean, right, to try to pull that data from the community. Yeah, I mean, I think it is
It's interesting.
Yeah.
Animals are still not people of African descent. I
Right.
wonder, you know.
Right. Seriously.
I wonder why.
Yeah.
Yeah.
Might be
yeah,
a good case for reparations right there, though.
right.
Yeah. Yeah. I mean, I think the intergenerational trauma is definitely acknowledged within the field. I think, at least if we're talking about like professionals that are coming out in the field now and like more modern training, yeah, it's certainly there. It's certainly talked about.
Thank you. And Ren, I'm going to ask you a little bit. So I didn't get to see the movie Cured, because you have to like rent that. We might do that sometime as an education video. But they discussed the struggle to declassify homosexuality as a mental illness. Can you share with us a bit about that struggle and the stigma that still lingers today?
Mm-hmm. So, I mean, I'll be honest with you, I actually haven't seen Cured, so I need to see this myself.
You can come to our screening.
Yeah. So Yeah, homosexuality was in the DSM as a mental health disorder up until, the DSM-5 was the first without it, which was 2013. It's really not that long ago. I think one of the things you asked about was like how that stigma continues. And one of the things that immediately came to mind for me was thinking about conversion camps. I don't know like how familiar you are with that, but like the idea of like, sending youth and even adult, there are adult programs for folks that go with this idea that homosexuality is something that can be like cured or changed in some way. And these conversion camps have caused a lot of harm and a lot of trauma for folks. And so it seems that, now we've moved to this fight in terms of changing legislation so that these conversion camps can't happen, which I think is great. I think the other thing I was thinking about is like at this point, gender dysphoria is in the DSM, right? And so when it comes to trans identity, gender dysphoria being in the DSM it's kind of this double-edged sword where it becomes this golden ticket for accessing care, right? That's the diagnosis, just like we talked about accessing therapy, that's the diagnosis you hand an insurance company in order to get the care that you need covered. But also that means that your gender identity is being identified as a mental illness, right? And so I'm really curious about, how that, fight to declassify or depathologize identity will play out when it comes to gender dysphoria as well.
Are they working to have that removed right now? Do you know?
Not right now. I mean, I don't think I think accessing gender affirming care at this point has like become this very very precarious thing. And so the idea of kind of touching that, this piece that makes it accessible, I think feels kind of frightening right now.
Yeah. Delaware did pass a bill banning conversion therapy and also criminalizing if you were to send your children to another state if you were a Delaware resident.
It's great.
So Delaware did do something in that space. We're not all bad. So with and any of you may be able to talk to this, to be honest, it's just across the country right now, well, there's a lot of things happening, but the trans space, there's a lot of criminality being found in that. So much so, I mean, somebody had their pronouns on like someone, I think one of the mass killing guys, and so people were like, oh yeah, they're mentally ill. They had their pronouns right on their screen, and I was like, that's where we're going. But do you have clients that are like petrified right now that I can't imagine you do.
Yeah, of course.
Yeah.
I mean, I think, I have conversations pretty regularly as people talk about their like the realistic possibility of leaving the country, right? Making life choices around career or partners or, those kinds of things, holding in mind, oh, I might have to leave this country. Is this a profession or a licensure I could take with me to Canada or to Europe, right? And kind of holding that in mind. Yeah, it's a pretty, from a national legislative perspective, it's a pretty rough time right now. I mean, it limits where folks can travel. It limits like what family they feel like they can spend time with. Yeah, it's definitely taking a toll.
Yeah, we tend to, I know I talk about Delaware a lot, Keene, I live here. And while Delaware, I think Delaware generally, you would think people are safe, but people don't feel safe. It doesn't matter that right now what Delaware's law is, because things trickle past, right? Like things just kind of come from a place and then they end up there. Do any of you have any kind of on the intersection of queerness and color? Do you guys, is that like you have to add an additional space there to process through that, right? Just the way our society treats people.
Yeah, absolutely. Absolutely. There was a discussion I remember during my master's program where they asked all of the people in the classroom, like, would you let your boy wear a skirt? And I was one of only 2 Black people, and everybody was like, yeah, I'd let my son wear a skirt. I don't care. And I was like, it's so interesting how everybody was really quick to say, yeah, I'm thinking about my Black son wearing a skirt and how the world is going to view him. So it's that intersectionality of race and gender, and then your gender identity. And so it is that added layer that you're talking about. And for some people of color who have, varying gender identities, as Ren is saying, like it might not be safe for them to come out to their parents, especially if they're at risk for homelessness or, being ostracized from their family members, or in some extreme cases, maybe even being harmed, and so it is important. I always like to say that as, progressive as we are becoming, it's always very important to make sure we're not using a westernized ideology with clients who might not be able to, they might not have the privilege to adapt that ideology as well, because it might not be safe for them. And it might, sound crazy, but you might have a client and you might ask them, okay, what do you want to do? And you want them to come out and you want them to be free. And they might say, I'm choosing my family. I want to stay, concealed. I don't want my family to know. And learning how to support your client through that is important.
Yeah, didn't think about that. Thank you for that. Let's talk real quick about, I shouldn't say real quick. So 45% of the LGBTQ community, the youth, seriously considered suicide, and that information comes from the Trevor Project. Can we talk about that? Can we talk about, Ren, are you familiar with the Trevor Project? You want to share a little bit about that for those that don't know?
Yeah, so Trevor Project is an organization that supports LGBTQ youth and adults. They do 24-hour suicide hotlines. They also do advocacy and like legislative support. Yeah.
Cool. You guys, people can Google that if they want to. I was just going to say the answer to that question is going to be that I was going to ask is tomorrow's going to be like, it depends on individuality. And it does when we're talking about, especially a situation as severe as suicide, because now we're finding between mass shootings and just guns being available, that guns are now the #1 killer of youth from car accidents. And not that we're going to make this about guns, but when it comes to suicide, that's one of the biggest things. People are successful if they have access, right, to ways to do that. How do you guys handle that just in general? I know you have to, I know there's a whole situation there, but is it as common as people say in the youth population, contemplating suicide?
I mean, in my client population, yeah, absolutely. I feel like I'd be hard pressed to think of a client who I haven't had a conversation about suicide with, even if it's not present today, even if it's talking about at other points in their life.
It hasn't been something that I've had to address often, but it's definitely there. And it's always one child too many. So yeah.
Yeah, of course.
Yeah, I think about the in talking about like the suicidality throughout their lifetime. I think one of the things that's really hard to hold is how many stories are like during early adolescence or mid-adolescence, right? And how alone they were, that they'll tell me stories about suicidality at that time that no one even knew it happened, yeah. And I think it just emphasizes how important access to services at that age is.
Yeah. So let's talk a little bit about youth and mental health since we're here now. Do you think that currently there's now less stigma when it comes to mental health in the younger population. I know we talked about that a little bit before we went on live. And what are the main mental health issues you see with children and youth? And you can add COVID into that. So that's kind of like a rolled up question. Talk about COVID. What are the main issues? And then what was the first part of that? You guys got it better than me. Is there less stigma now? So Marsha, why don't you go? Tomaro, you're already off. Good.
I think that there is less stigma with youth. I actually find that a lot of the clients that we have that come in that are under 18, they're actually asking their parents to help them find someone to talk to. So that's something that I've seen increase even prior to COVID. So I'm excited. I'm always excited about that. Every time I hear of a person that, was asking for that help, and then and it just helps them to become more involved, and they know what they want, and that's something that I've been finding happening much more over the past like 4 or 5 years. Much of what we see come in is anxiety. We do have a lot of depression, and we have a lot of trauma. And trauma comes in so many different forms. It's not always what we view trauma to be. Someone may say, oh, well, I was abused, or I lost someone to gun violence, or I'm seeing trauma come in much lighter forms. And I hate to use the word lighter, because everybody's trauma is their trauma, no matter what it is, across the board. But we've been seeing a lot more of that happening. So I think we need to sometimes take a step back and reevaluate what trauma really is, because again, that's individual, just depends on the person. After COVID, we started to see an increase in the anxiety piece. I think that a lot of kids were the uncertainty. A lot of them lost people. We definitely saw an increase in kids that were coming in trying to deal with grief. And then we had like the whole George Floyd thing, and that took the whole country on a whole spin. So that was something else, especially our children of color coming in and dealing with things that was associated with social media. Everything that they can possibly think of that's negative is there. And I think that for us anyway, that definitely trauma, anxiety, and depression have been the 3 major issues that we've had come across with our young people.
How about you, Ren? Do you feel the same? I think it's the exact issues that Tomaro just talked about. Those 3 things are additional things. Like, I'm sorry. Sorry about the anxiety.
Did you say my name first?
Yes.
I'm sorry.
Yeah.
I missed that.
That's okay. That's okay, Ren. I'm sorry. Yes.
Yeah, I mean, absolutely. I think, yeah, I would agree with everything Tomaro's saying. I think I think even like as a parent myself and listening to like my kids talk about mental health and talk, like they chat and they're like, oh, this is what my therapist is like. And this is how how therapy goes for me. And like, oh, your therapist is like, well, maybe, do you think maybe you want to see a different therapist? Or like, do you think that works for you? It's pretty awesome how they talk about it together and support one another in going to therapy.
Awesome. That's awesome. Marsha?
Yeah, I definitely think that mental health is becoming way more normalized, and I definitely think that social media plays a role in that. And I think that social media has its pros and its cons. And so on the one hand, I do think that social media is contributing to the rise of mental health concerns, but I also do think that it serves as a tool for knowledge and education, and it is, essentially disseminating information to young kids. I also think that it works really well with the culture of young kids, where we live in such a microwave society right now, everybody wants things that are like super fast. And so with TikTok, watching a 60-second reel and, you know, certain like catchphrases or buzzwords for mental health is being shown to kids. And I think they're grabbing onto that. And it is our job, you know, like as parents, as teachers, as clinicians, to also kind of, you know, help them understand how to differentiate between what's facts and what's, you know, just like TikTok information. But I do think that it is really neat that they are using it as a tool to learn and, you know, having conversations amongst themselves and stuff.
Yeah, that's great. You kind of brought up a thought, Ren, when you were talking about your kids oh, do you like your therapist, you want to try someone, and one of the things that stinks is, while sometimes you might want to try somebody else, it's hard to get one person, right? And so it's like I've had friends who are like, I just don't click with my therapist, and I'm like, well, keep your therapist but start looking for a new one, because it's like it's hard to get on a list. Marsha, that was good to hear. Mental health in schools, so this is obviously a huge push now. Delaware pushed a big bill. My question, since we pushed it, has been, where are the people that are going to fulfill all these positions? Sorry, I'm not making light of it, but I'm like, that's great that we're going to require this. And now I think we went from elementary school this year, we're going to do junior high, and then next year they're aiming for senior high. Talk to me about how important that is and what you think the reality is of what kind of kids get in that space right now.
I think that Marsha made a good point earlier when she was talking about prevention. And if you want to start anywhere, the best place to start is at school. And I would say if it can't be as early as nursery, then elementary is where we need to be greatly focused. And yeah, of course, you know, sprinkle a little bit in all of the other schools as well. But if we start off in elementary schools, that is a great way to kind of combat some of the stuff that can happen later. One of the issues that I think I find or have found with the schools and trying to get therapists in the schools, I totally understand, you know, the whole having to have licenses and, you know, held accountable to the state in that sense. But what I find is that when we have so many young people that could benefit from preventative mental health care, I find it difficult for me to accept the fact that the only way that this can happen is if we have a slew of licensed therapists going into the schools. And if we don't have the licenses, then the children will miss out on the opportunity to get the assistance that they need. Whereas we should probably be focusing on, let's get some people in who can have a passion for such a job and train them by licensed therapists, and let those people go into the schools and do what they need to do to help prevent some of the stuff that we're going to see in these kids later. And that's something that I think is a huge issue when we start talking about, okay, so how are we going to fill the shoes of people that need to go into the schools and provide these services? It's going to be even more harder as we start to look at the fact that they have to wait for a licensed therapist to be able to do it. When we have so many qualified people who can be trained and, you know, put in those places, and it just boggles me. I'm boggled by the fact that nobody seems to realize that there's other ways that we can get involved. And, you know, and teachers, you know, the teachers are with these kids 24/7. Why don't we have trainings that teach these teachers even how to recognize certain issues, how to address the issues, give them the tools that they need to help the students, to help the class, you know, the classes excel in certain mental health spaces. And so there's quite a few things that bring up a concern when we start talking about all of these opportunities to go into the schools. It's needed, but there's also other stuff that have to be addressed with it.
That's a great idea. I mean, preventative is yeah, that makes a lot of sense. I don't know why we're not doing either. Tomorrow, maybe you need to pitch that. Marsha?
Yeah, I definitely agree with everything Tomaro said. I think that it is really important to not focus too much on the whole licensed psychologist, licensed counselor, because again, there's disparities in higher education. And so I do like what Tomaro's saying about we being the ones to train people that are there, training teachers, but also providing support, because teachers are already kind of serving as the parents, the teachers, and the therapists. And so providing more support for teachers. There's just so many disparities in the school system. And so whether it's, having a little bit more flexibility with school counselors and not requiring them to be licensed, or whether it's creating, interdisciplinary teams with maybe every student or every class has, a school psychologist, a school counselor, a teacher, a person in admin, and they're essentially there to provide support for everybody. Something like that could, also be helpful. But I do like the notion of not having that requirement of, for counselors and therapists to be licensed, because by the time they go through that journey to get that license, they might, be experiencing their own form of burnout, might not want to, work in the school system, or, it might be too late for kids. So it just kind of, depends.
Ren, your thoughts?
Yeah, I think one of the things that you mentioned in this question was the idea of like who would get those resources and who wouldn't. And I think it, really makes me think about like the amount of like racial bias and gender bias that's going to go into, okay, which student gets sent to the school resource officer, which student gets sent to administration, and which student gets sent to the mental health services, right? And I think if we're not watching that, right, if we're not like, being mindful of that and being purposeful about that, right, we're going to fall into some patterns that aren't actually helping, all of the students and the students who need it the most. I think the other thing that I'm thinking about is like, we've talked about the stigma of mental health, and it does exist. And so like as much as we want to destigmatize mental health, there is this question of like, okay, when we mix both mental health treatment and school, what does that mean for like the sharing of information or the sharing of diagnoses, or at what age you get handed a diagnosis and like how accurate that is, or how long that follows you, right? Or how that changes how your teachers may judge your behavior, right? So, I think that it feels so needed. And also there are these spaces that I'm like, oh, there's these pieces that I would want to be really mindful of. Yeah.
Yeah, I think that's exactly, I think a little bit to Tomaro's point is, if you want to look at the representation period, right? Having people that care about this particular topic and teaching the tools for individuals to deal with, because I think a lot of times mental illness is obviously it's a buildup, right? Of not being able to process things from the beginning to where you are now and not having those tools. But someone who may not necessarily be a clinical psychologist can certainly, I mean, honestly, sometimes yoga instructor, right? I'm not just saying that, but I mean, that preventative things like learning how to breathe, restorative practices, those kind of things could live in our school system so that we don't just have, you're right, like where the resources go. Well, it's 8:05. I'm only keeping you guys till 8:15. But sometimes people have questions. I didn't see anyone pop any in here during just kind of some comments, which was just concurring with what everybody said. Yeah, Sharice mentioned COVID. Anybody have any questions for our panelists? If not, I'll keep asking them questions. All right, well, I'll let people think about this. What are your thoughts on mental health as a disability? And I say this because there's a schism of mental health issues, right? And then we have disability. So to what, all right, Lisa, will after they answer this, we'll answer your question. If anyone has an answer, I don't know.
I think that's another one that's a little iffy, and we have to be careful. I'm always, I'm always etchy about just diagnosis, period.
Mhm.
Whether it be for a client who's an adult or child. When we start throwing out diagnosis and you know, it kind of, I think that a lot of times when we think about, like, for example, we have to diagnose for to get reimbursed by insurance companies. And I think it was Ren that mentioned, you know, how long does this follow you? You know, what is this particular diagnosis going to do for you in the long run? Because, you know, okay, if I have to pay to get a diagnosis today, I don't want that. And I'm 14. You know, what is that going to do for me when I'm 25? You know what I mean? And all I needed was just somebody to talk to for a few minutes. Or I'm so stressed out at this particular point in time that I do need a medical diagnosis that would allow me to be home for a month. But then what happens later when I go and I try to get in, you know, join a service, or, you know what I mean? So it's such a sticky situation when we talk about diagnosis, period. And then now we're talking about it becoming something where it's you know, that that's a tough one for me to accept and not accept. I'm kind of just on the fence with it.
Yeah, yeah. It sounds like you're envisioning a more of a holistic approach anyway. Of
Yes,
you know,
yes, that's how
I think most that, I mean, like, that's the thing, is we have to do what we have to do to get paid and the insurance and all of that stuff. But it sounds like all of you are kind of like, our practices could be better, our clients could be better served without
yes.
having to put labels, I mean, on any of us, right? Especially, we know that this happens. We did talk about disability on the first Let's Talk. And one of the things we talked about were kids getting labeled. And we had a mother advocate on there, and her child at 2 years old got kicked out of daycare. Now her other kids still go there, because when that happened, she went and became an advocate and learned everything she could. And you know, what the best situation was for her son at the time. And then she had additional kids who, the people in the daycare now come to her and say, hey, parents are having an issue, you know, would you talk to them about what their what resources are out there for them? So, you know, personal experience. But again, had she not been able to be as conscious, you know, of what was going on with her son, he would have been kicked out of daycare, right? And I think, what does that lead to? I think we all know, right? That's the really early prison to pipeline, because, and we know that that happens. I think, Marsha, you talked about how it happens much more frequently with Black boys, and then Black girls, and then, you know. So, all right, somebody put something in the chat. Let me see. I don't know if it's a question or not. As a white woman studying an MHC program toward LPC, I'm sure you guys understand what those initials mean. Can you recommend avenues to awareness, relationships, and action to become more confident in the ability to counsel people of color or marginalized populations?
One of my suggestions, and this is just a personal one, a personal growth response. I can't remember if it was Marsha. One of you young ladies mentioned about you don't necessarily have to be a person of color to relate to a person of color, or gender identity or whatever. I think that any of us can serve anyone as long as we're willing to listen, learn. And I mean, I may have a client that I don't have a clue. I can't tell you, Ren, I can't tell you how many times somebody will come with me with some letters. And I'm like, okay, I don't know what that is, but next session, I promise you, I'm going to be able to address it. And if I can't, I have someone in my team that will be able to, you know, to work with you on that, because I know that my specialty is not LGBT, but I'm going to do everything I can to help. And if I can't, I find someone. So I think one of the important things is for us to recognize our abilities, learn what we can learn. If you don't know it, don't act like you know it. Go find out, or else refer the client to someone who can help them. Our goal is always to make sure that we're helping and not hurting. So I don't know I don't know of any particular place you can go or anything to gain the knowledge to help people who are different than we are. But I think that it's just as a matter of like, hey, I don't understand this and I'm going to try to learn your culture. I'm going to try to understand your culture. I've learned so much, me personally, from people who became clients mainly because they were like, okay, but I appreciate the fact that you're willing to learn, so I'm going to stay with you. And they teach me just as much as I teach them. So I personally don't have a recommendation of where to go for anything specific, but that's just a personal growth suggestion.
Yeah, and just going off of that, obviously, like there are, you know, ways to formally like educate yourself, like reading certain books or certain documentaries. There's even this one book I know, it's specifically designed for clinicians to help clients of color. So there's books out there, there are resources out there, but I also really do, I think that interpersonal relationship that you're going to cultivate with your client in session really matters. And I think it's important to just name it. I like how, you know, even in this question, you said as a white person, you know, I think it's important to like name your positionality because it is going to show up in the room. And so there's no point in avoiding it. And so if you have a client of color, you know, asking them, what does it feel like to have a white therapist? You know, what does that mean for you? How do you racially or ethnically identify, and what does your culture mean to you? The client might say, you know, I'm coming to talk about my anxiety that actually is not related to my race at all. And that's okay. Or they might say that my anxiety is related to my race. And so just asking them what it means for them is really important. I think that you know, the work that we do when we're trying to help people, we're trying to heal people, we're trying to empower people. I'm not going to say that color and identity doesn't matter because it does matter, but I think helping the clients is what really matters to them the most, and showing them that you care. And, you know, as Tomaro was saying, if she doesn't know something about a client, she will, you know, study, she will, you know, research and then come back to the client. That shows the client that you're invested. It shows the client that you care. It also shows the client that you're humble, that, you know, you don't know everything. The moment we start to say, well, we're culturally competent, we know everything, then we stop growing, we stop learning. And so I think it is important to, you know, always stay culturally humble so that you can learn from your clients while also doing your work, your own work to educate yourself.
Yeah. I think, like, especially as a white woman in this field, it is so easy to look around and realize that your entire circle is also just white women. And that is not going to be very helpful in your learning as a clinician, right? And so I really think about, like, you know, check out the authors of the books that you're being assigned. Find other authors, right? Check who you're following on Twitter, you know, on your professional Twitter, your professional Instagram, right? Are you just getting a mirror of your own face, right? Or your own lived experience? Then, you know, then you need to find other voices and you need to learn from those folks.
Thank you. Thank you all so much. This was a great conversation, and it could keep going on and on, unfortunately. But I don't even know 5 years ago if when I started, we would have had a Let's Talk Mental Health. I think COVID did amazing things for mental health in the space of us all being able to acknowledge that it was not normal. None of what we were going through is normal, no matter where you were in space. You know, I think that was one of the things. None of us have ever dealt with it. And we were like, oh, you should do. No one has been through that. We can't know what we should and shouldn't do. I mean, hopefully we've learned some lessons now. But yeah, and the kids now have had, you know, what are they? They're going to be called COVID kids, right? Later in life, they're going to be called the COVID kids. They were a COVID kid. They don't talk to people. I don't know what they say. Do you guys have any closing comments or anything? And Lisa, by the way, thank you very much for asking that question. You know, Marsha, I appreciate you kind of pointing out it. One of the best things is being humble, I think. And for me, being a white person in anti-racist work, definitely. But I think for all of us to just be humble and come from the space that we don't know everything. Even if we've heard somebody's experience, it doesn't mean the next person's experience is the exact same thing, even if it seems like it is. So. keep that in mind. Ladies, do you want to do anything closing, or you just want to go by, or what do you want to do?
I just want to thank everybody that joined and asked questions and were engaged. I think that part of, the work that we're doing is having these conversations. And when people are able to join and people are able to, access this as a, tool of knowledge, and it's really important. But I'm really big on, spreading the messages. So not having this discussion just stay here, but also, talking it over with a coworker, talking it over with a friend, talking it over with, your kids or your friends, or, anybody. I think that is really important.
Agreed. I obviously, I suffer from depression. And, it took me a long time to talk about it, and very much ashamed of it. And recently I ran for office, which is another thing, but I did a whole letter about my struggle with depression, and acknowledging that it's okay. Like it's okay. But it's been a struggle for me. I can imagine it's a struggle for everyone, but I think generationally, the older you get, the worse it is. Because my family just used to call my mom Crazy Kate, because there were no things for her to take at the time other than Valium. So, Ren, do you want to say? Sorry.
Yeah, I think I would just echo the same as Marsha said. Thank you to everyone for coming. And yeah, if you want to continue a conversation, you can reach out to me.
Thank you. Tomaro?
I just want to say thank you as well. This was a great talk. I even actually learned a couple things, which I appreciate. I just want everybody to know and understand it's nothing wrong with needing to talk to someone. We all should have someone to talk to. I think, Becca, you said that everybody should have a therapist. Can we all have one? No. But if it's not a therapist, it could be a friend, it could be a sibling. Always find someone to talk to. You'd be surprised at stuff that you learn about yourself and your issues, ideas and things that may pop up that can help you if you just have a conversation with someone rather than keeping everything to yourself. To us Black women out there, we do not have to be strong. It's okay to have some form of weakness. We are human, regardless of what we may have been told, during enslavement and so on. It is okay for us all to need help, and we should definitely seek it. And also, just it takes a village. If you see something, say something. Always be willing to help and open up to help, others, because you just never know. And be kind. That's all.
Yeah, absolutely. Absolutely. Thank you. Thank you so much. Tomaro, it's funny you said sometimes you learn about yourself. And I think the real challenge is people understanding that really you have to do the work when you go to therapy.
Absolutely.
It took me, I for a long time, I was like, you gonna fix me?
Yeah, it drives me
No.
nuts when a person says, they tell me the story and they say, so what should I do? I'm like, I don't know. What should you do? Can we talk about it? Because I'm not going to tell you. So you can come back and say, well, Tomaro told me to do X, Y, and Z, and my life is in shambles. Absolutely not. We all have within us what it is that we need. Just has to be pulled out sometimes.
Thanks, guys. Have a great night.
You too. Thank you, Becca.
All right. Bye-bye.
Good night,
Thank
ladies.
you. Bye.